Let's put some numbers on this then. Financial impact, if you will. Diabetic foot ulcers, the impact of this problem to the nation as a whole. How big is it? How much does it cost?
It is the major complication associated with diabetes generally. Diabetes can be well managed. There are many diabetic patients who never get a wound. So if you want to ascribe a cost to diabetes, the wound is the primary driver.
It's the driver.
Absolutely.
Right.
That's what turns manageable diabetes into a very high cost center.
All right, that's an important statistic to know. What about peripheral vascular disease as divorced from diabetes? People have PVD without diabetes. How does the cost of that compare? For example,
if it's not
diabetes
appropriately diagnosed or appropriately managed, if there isn't the ability to work with or see a vascular surgeon, it depends on the level of specialty care and what environment the patient is trying to navigate in based on their particular circumstance, whether it's a payer environment or not.
I'm going to make a comment that may shock you.
I'm easily shocked, apparently. I've been shocked a lot so far.
50% of all diabetic patients who have non-traumatic amputations never have a vascular evaluation of any kind.
All right, I'm shocked. That's insane.
Yeah.
I mean,
So it shows you the range of how these patients can potentially be treated.
Wait, let me see if I understand what you're telling me, and I'm not trying to be facetious here. We have a disease. One of the major complications of this disease is vascular disease with poor perfusion to the distal extremities, and it's a known offender in this regard. How would you evaluate? I mean,
Well,
it doesn't happen very often.
And there's something else to keep in mind. I mean, with the new endovascular techniques being so advanced and often so successful, it's still shocking to me that so many people never have the ability to get to that specialist.
I mean, nobody looks at their peripheral pulses?
I'm not saying nobody, but
it's
I'm saying
rare,
50%.
or 50%.
Well, 50% have never had a vascular evaluation of any kind, including an ankle brachial index. Nothing.
Right. Look at peripheral pulses. Look at the skin color. Look at capillary refill. They don't do that?
50% of those patients don't ever have a
This just
vascular
speaks to
evaluation.
Makes me sad.
This just speaks to the segmentation issue in medicine. You know, again, you go to this specialist for this treatment, and that specialist thinks within the specialty box and maybe doesn't make the appropriate referral or think outside what other issues underlie this condition that I'm treating. And, you know, we need to break this down.
I mean, you got to break
these
this up.
silos.
And we mentioned earlier specialists, and to expand on the point brought across by Dr. Snyder, that specialist from a managed care perspective or from a payer perspective can be an organization. We talked earlier about carving out wound care as a chronic entity. Well, if you establish an organization comprised of a multidisciplinary group of specialists in a risk-bearing entity where it is carved out, then you start bringing the advantages that managed care has brought to other chronic conditions where it's better quarterbacked or better managed.
I had one of the comment you had mentioned.
You keep shocking me. Please, come
sorry.
on, bring it on.
You had mentioned peripheral arterial disease.
Sure.
So I'm doing some work with the Critical Limb Ischemia Association, and we're looking at creating a checklist for the generalist to make sure that an appropriate referral is made. And as you know, checklists have to be very specific and very short so that they're easily used and comprehended.
Or they're driven by the EMR and they're annoying. So go ahead.
Well, in this case, we're trying to keep it medically oriented. But the point I'm going to tell you is that the first question is, did you take the patient's shoes and socks off? So it gets that rudimentary because
Really?
in many clinicians' offices who are practicing general medicine, either they're not even addressing the patient, or if they do, they tell them to strip to their shoes and socks.
Yeah.
So they don't even evaluate their lower extremities.
The pun is so obvious. They're not just addressing the patient, they're failing to undress the patient.
To undress the patient, that's true.
But
it shows you how simplistic
it's
we really have to
rudimentary,
get.
isn't it? I know we've discussed this. Why don't somebody just lay out the hidden costs of wounds caused by these comorbidities, other than treating the injury itself? Where are the hidden cost centers to America?
Well, we talked earlier about the bureaucratic cost of
I really loved that comment.
of the cost of
Yeah.
treating a
Bureaucratic
wound. There's the
versus-
physiological time, which incidentally is very, very hard to pin down. If you were to look up what is the length of time that it takes to heal a stage 4 pressure ulcer, the literature is varied. There's a consensus that it takes over 120 days. Now, is that 120 days a physiological reason for why the wound can't? We accept it. Wow, these take a long time. But what happens is, and I think we'll get to this in subsequent questions, is the industry as a whole, or medical care as a whole, is firmly established in establishing a chronicity over a 30-day period of time for that wound. And then we start looking at other, quote, high-cost modalities in order to bring them in as as magic bullets.
In other words, they've got to
at the
meet
end.
that threshold in order to get the money. to
Correct.
treat.
And the cost versus time matter in determining what it takes to heal a wound. Because if a home care agency identifies a wound, a pressure ulcer, that requires a low air loss mattress, it can take 2 weeks to be able to get that order or that indication to the gatekeeper's desk, to the provider for actionable information. Now, in our work, we found out that we could heal the vast majority of wounds in under a 90-day period, and it had nothing to do with using magic bullets. What it had to do was proper coordination of care and cutting out the red tape. Now, what's that cost?
It's not to anyone's advantage to isolate.
It's
and
more.
And there's something else to keep in mind. There is some good evidence that shows that the earlier you institute any kind of advanced therapy, the better the patient will do.
Doesn't that fall into the
Yeah.
category?
Well,
And
I
that's where
think-
risk comes in.
Yeah, that's
right?
where the risk
a risk
comes in.
entity where managed care plans have the latitude to be able to do
Okay.
that, can establish mechanisms by which the most appropriate care in a well-regulated environment can be instituted early on, so that a stage 4 doesn't have to be going through the stage 2 and 3 in order to be able to have the appropriate care at a level 4.